Good evening and welcome back to the Lipid Panel. My name is Dr. Dan Soffer. I'm the co-chair of programming for the Lipid Panel, working alongside of Dr. Ann Carroll Goldberg and Brittany Thompson. The Lipid Panel was conceived to be lipid clinic conference on a national scale. For those of us lucky enough to have in-house colleagues, Lipid Clinic Conference is a great way to debrief after busy clinic, to review diagnostic approaches, how to interpret clinical findings and generate therapeutic strategies, and maybe most importantly, to come together with colleagues. For the rest of us who feel like we're on lipid islands, conferences like this remind you that you're not alone. There are other like-minded colleagues and professionals who want to have the same conversations you want to have. If you have cases that you want to be presented at future conference, please email Brittany at bthompson@lipid.org. That's BTHOMPSON, and Brittany will put her email in the Q&A and chat with your suggestions. In this series, we'll review common presentations of rare diseases, atypical presentations of the common conditions, sometimes even common presentations of common conditions, and we'll try to cover as many important clinical topics every lipid specialist needs to know. This series is meant to be a monthly coming together of rising stars from the FNLA lipid scholars and early career lipid specialists and more experienced colleagues. Look for our schedule posting for the final Tuesday of every month during the academic year. This evening, I'm joined by a superb panel. Dr. Deepak Vedamurthy, who is a preventive cardiology fellow in our program, will be presenting the case. He's a fellow in preventive cardiology at the Pennsylvania Hospital in Philadelphia and interested in pursuing fellowship in cardiology. Dr. Ann Liebeskin will moderate the program. Our panelists tonight include Dr. Noreen Nazir and Michael Shapiro. Dr. Nazir is an assistant professor of medicine and cardiology. She has an interest in cardiovascular disease risk reduction and management of cardiovascular disease risk factors and risk enhancers. She's been actively involved with the National Lipid Association since cardiovascular fellowship training and is the president of the Midwest Lipid Association chapter of the NLA. Our other panelist tonight is Dr. Michael Shapiro. Dr. Shapiro is the Fred M. Parrish Professor of Cardiology and Molecular Medicine at Wake Forest University School of Medicine, where he's on the faculty of the section of cardiovascular medicine. He's the director of the Center for Prevention of Cardiovascular Disease and co-director of the NIH T32 Fellowship Program in Cardiovascular Disease Epidemiology and Prevention. And he's currently the president-elect of the American Society for Preventive Cardiology. In a minute, I will turn over the direction of this program to our moderator, Dr. Ann Liebeskin. Dr. Ann Liebeskin, MD, FAAP, FNLA, is a clinical lipid specialist in private practice serving the Northeast Wisconsin. She's board certified in internal medicine and pediatrics and one of the early diplomates of the American Board of Clinical Lipidology in 2006. She's an adjunct assistant professor of pediatrics for the University of Wisconsin School of Medicine and Public Health, and her clinical interests include pediatric patient education, patient engagement, childhood obesity, and treating families with inherited lipid disorders. She wears many hats at the NLA and is an advisory board member for the Wisconsin Medical Alumni Association. Welcome all to the Lipid Panel, and I turn you over to Dr. Liebeskin. Dr. Liebeskin, it's all yours.
Welcome, everyone. Thank you, Dr. Soffer. I'm looking forward to this case tonight, and we will be led by Dr. Vedamurthy, who will present the first part of our case.
Okay. All right. Thank you, everyone. And thanks, Dr. Soffer, for giving me this wonderful opportunity to be with this all wonderful panelists. Just like what Dr. Soffer alluded to, the case we're going to talk about today is one second, it's not forwarding. It's a simple presentation of a simple classic case which presents to the preventive cardiology clinic. So there's nothing fancy here, nothing unique about this case. It's designed to kind of encourage an open discussion, and I hope you all enjoy this process. Perfect. So this is a 55-year-old Hispanic lady who presents to our preventive cardiology clinic at UPenn for a routine health evaluation.
And Dr. Vedamurthy, I'm going to stop you right away. By the strict direction of Dr. Soffer, he would like me to ask a lot of questions tonight of our panelists. So we're going to start right there. When you hear those first tidbits, there's a wealth of information with every bit of patient history. So when we see that first line, what do our wheels start turning of as clinicians? Dr. Shapiro, would you like to take a stab at that?
Sure. Yeah. I mean, this is a rich case right off the bat. I think, Deepak, you've handpicked this very nice case. So yeah, this is a middle-aged woman. Right away, we see that she's from an ethnic minority, and that sort of gets our attention a little bit, just in terms of thinking about risk-enhancing factors. But I think this is going to evolve very quickly. So I'll leave it at that for the moment.
I did want to add one thing. So he's written Hispanic, but he was able to give us this information of Dominican Republic, because I think, as we'll maybe discuss, often Hispanic or Asian, those are groups that are very diverse and their risk gets aggregated, but getting that extra bit of information from where hopefully will be a little helpful for us later on.
Perfect.
So she hasn't seen a doctor for many years, but now she wants to get back on track. She says she does not take any medications. She tells us that a few years ago, like actually many years ago, she was found to have a mildly elevated blood pressure and mildly elevated cholesterol. And she was prescribed a cholesterol medicine, which she didn't take for too long. She thinks it's a statin, but doesn't recall the particular generic name or the dose of the medication.
And did she give you any indications there of why she didn't continue it?
She said she didn't tolerate it because she had some muscle aches.
Okay.
Yeah. And the only other medical issue she has right now is a mild psoriasis, which is managed with topical steroids. She does not take anything systemic for that.
So Dr. Nazir, as you hear a little bit more about this, what does that start to make you think and wonder?
Well, I'm really glad that this history has been taken, because it adds to the risk that's already in my mind with the psoriasis, that enhanced risk factor. The fact that she's got these cardiac disease risk factors and have not been maybe on medication, not taking them, I think that's a little bit more information to dig into, but it's really making a story of a lot more than just a 55-year-old woman coming into the clinic. There's so many factors here that are increasing her risk. We know even the ethnic kind of background, a little bit more detail, these other risk factors that are the traditional risk factors, but then the psoriasis, that enhanced risk factor, is just adding up more and more to make a case for a lot that needs to be done in setting up risk reduction.
And when we've alluded to the fact that psoriasis is a risk enhancing factor, or a risk factor, what really is the core of that? Why are we worried about that?
Yeah, that's a great point. I think what you're getting at is chronic inflammatory diseases are certainly associated with substantial increased risk for atherosclerotic cardiovascular disease. So we'll have to see how this plays out a little bit.
Yeah, it's considered one of the CIDs, so we'll have to take a look.
Correct. And just to recap for those who might not be following our line of thinking here, in 2018, the cholesterol guidelines, the multi-society guidelines, really started to outline and add to our guidelines the importance of chronic inflammatory conditions. We've always known that in bits and pieces, but I think it really took a forefront then. And so it's helpful for us to realize these chronic inflammatory conditions really move up as enhancing factors. And that's what our panelists are worried about. Dr. Vedamurthy, let's move on.
All right, sounds good. So as far as her other past medical history goes, she really does not have any evidence of clinical ASCVD, no history of MI, strokes, or hospitalizations for any reason for that matter. And particularly related to the lipid history, no history of acute pancreatitis.
And why did you pick out those two things to tell us about compared to everything else?
Yeah, so obviously one of the things I'm worried about is whether she has uncontrolled hyperlipidemia predisposing her to clinical ASCVD, and whether she has a history of high triglycerides that predisposes her to acute pancreatitis. So that was the important history I wanted to, kind of the negative history I wanted to get from her. I know the significant history, no personal history of cancers or any other complicating kidney disease or liver disease of that sort. Okay.
Right.
Past surgical history, she has a history of appendectomy and cholecystectomy many years ago. And as far as her obstetric history goes, she has history of 3 children. All of them are full-term normal vaginal deliveries, no history of preeclampsias or gestational diabetes, She's currently perimenopausal, not taking any hormone replacement therapy. During her reproductive years, she was on oral contraceptives, but nothing until the past few years.
Great. So there's a lot to unpack here. As we think about a 55-year-old woman, Dr. Nazir, we'll start with you. What do you see that's of value in this history?
So absolutely, I think touching again on those enhanced risk factors, getting this detailed history from the obstetric perspective, no history of preeclampsia or gestational diabetes, because if there was history of that, that would be adding to those enhanced risks. And the perimenopausal no hormone replacement therapy also is important in this type of patient population, female patient population. Of course, separate from that, it is reassuring that she's not had that end of MI, stroke, or cardiac disease. So let us see if we can intervene and prevent these things. But it is just further information about the risk in the OB perspective, and that we know hopefully we could intervene earlier rather than after she's had an event from these risk factors.
Absolutely. Dr. Shapiro, do you have anything else as far as history that you think of that you wonder about when you hear about a 55-year-old woman, or any extra details of this history that you would like to hear? Or do you think this is a pretty complete piece?
I think it's pretty complete. I think Dr. Nazir summarized the salient points really nicely in specifically looking at risk enhancing factors specific to women. So as she said, no obstetrical complications. She's 55 and now, perimenopausal, so clearly no premature menopause. So I think that's all very, very helpful. And as she indicated as well, looks like true primary prevention, no history of, clinical ASCVD in the past.
Now, if this woman was coming in and complaining that one of the things that brought her in today is that she's having intolerable hot flashes or things like that, where do you see that discussion going next?
Yeah, I think that's a great question. I think that would be a pretty lengthy discussion, trying to understand exactly how symptomatic she is from hot flashes and the implications of hormone replacement therapy, in women of this age. So we would have to get much more detail about her cardiovascular risk before we'd feel comfortable in thinking about prescribing estrogen replacement therapy for that.
Dr. Nazir, does that conversation come up in your clinic as well with women of this age group?
Yes, it does. It has actually. And with that conversation, I have educated myself quite a bit because that data has changed over time, and also what is first tested out in medical literature. But definitely, I agree with Dr. Shapiro. We need quite a bit more information on her actually cardiac disease risk and whatnot. Here, very good, but I think going into a detailed discussion and also kind of discussing with the patient the long-term versus short-term benefits of the medication is very important.
Absolutely. Dr. Vedamurthy, in your clinic, did they come up with a conversation about that?
Because no, we didn't have to. She didn't have any kind of like hot flashes or any of those symptoms. But yeah, that would be a common scenario where people report perimenopausal hot flashes, and we often have that conversation about the risks and benefits of hormone replacement therapy.
Excellent. I have to commend you that this is one of the better histories I've seen as far as female reproductive history. Oftentimes that gets so neglected in these cases. And so I was very excited to see that level of detail. I think there's so much information here to help you risk assess that often gets forgotten and never asked about. You had also mentioned some pearls about she had no history of cancer, so we're not worried about after effects of cancer treatments or things. So I really commend you on that. I would say that the other things that, you really hit the high points here of including things that are risk enhancers that were called out in our most recent guidelines. We know there are other risk factors such as perhaps premature or very delayed menarche, PCOS, things like that. They're not specifically called out yet because of some of the variable data, but we know there's some other things we could mine too. But I think this was a beautiful presentation of some of the really key points that absolutely have clear data that we have to ask this history in a woman of any age, but especially this age. So great job there. Go ahead and continue.
All right. So coming to the social history, she never smoked in her life, occasionally takes alcohol, doesn't use any street drugs. She's a retired hairdresser, high school education. She is married and has 3 adult children. The first child was born when she was 25 years old, and she lives currently with her husband who works in the construction industry. So a little bit about her socioeconomic status, kind of somebody who I would say is kind of in the lower to middle socioeconomic status and probably a little bit on the lower end of the health literacy scale. So that's
and what does that information give you? What are some of the things, for example, they're very specific in finding out when she first had her child, things like that. What are some of the pieces that are helpful here?
I think I'm not entirely sure about whether the age of first child has an impact on cardiovascular risk. I mean, like, I know that a premature menopause has a bearing, but I'm not entirely sure if the age of the first child has really an impact. I just put it across there as a history.
Right. Dr. Nazir, Dr. Shapiro, anything when you hear about this, about the social history, hitting on some of these things, what is helpful there?
One thing, yes, it's very important for that high school education level. One thing that we don't look at very much, but is very correlatory to health outcomes, economics, educational status, is if the patient is insured, and then how that allows their access to care. You know, sometimes I think individuals who are, as you related, maybe on educational attainment is not at a level that, or at a level that's here. Sometimes it's thought that, oh, their access to healthcare is limited, but it's also incorporating their access to insurance and how that allows them to access the routine healthcare. So that would probably be one other component to add, or just to know about, I guess.
I think I would also add, Dr. Vedamurthy indicated that maybe the health literacy is not optimal. So we don't want to take anything for granted here in terms of educating her about, this will obviously be something we get into in more detail, but making sure that she understands some of the basic tenets of healthy lifestyle for cardiovascular disease prevention. And it was indicated, I think, in the HPI that she was counseled perhaps on taking a cholesterol medication, but didn't take it, and perhaps it wasn't communicated effectively, why it might have been important for her to take a cholesterol medication. I think sometimes we fall into the trap of just saying, take a statin to lower LDL, as opposed to saying, take a statin to reduce your risk of a heart attack. So we'll just want to make sure that everything we're explaining is at a level that she can understand well.
Absolutely. And Dr. Nazir, your point of insurance access and things, sometimes we assume that a patient decided not to continue taking these medications and care, but was there an impact of that, to your point?
Yeah, and even on how Dr. Shapiro was touching on that, sometimes patients may relate, oh, I'm just not taking it, I haven't been able to pick it up, but is the reason they haven't been able to pick it up because they can't afford it or they don't have the coverage for it? So I think just knowing that information really would impact somebody who's having issues with taking the medication, for sure.
Absolutely. And how important is it to each of you whether or not she's a smoker and whether or not she's male or female and a smoker?
Smoking, very important for overall cardiac disease risk. So it's great that she's a never smoker. I think even alcohol, the other information here is also important from a cardiac disease risk standpoint as well.
And I think there's some, oh, go ahead, Dr. Shapiro.
Oh, no, I would agree completely with Dr. Nazir. I mean, smoking is incredibly potent risk factor, and something that we always discuss with patients for sure.
And I think something that isn't always intuitive is the fact that women carry a higher risk from smoking than men. So at her age, had she come in as a smoker, we would worry that that had elevated her risk significantly more, for sure.
Since we're just talking about smoking briefly, it has been noted as smoking, but now, and sometimes this may even escape when you're doing that assessment for the electronic nicotine delivery system to be incorporated in your smoking assessment, not just thinking about the typical commercial cigarettes available or whatnot. So even in the assessment, make sure that's being discussed as well, because they contain nicotine, of course, they have tobacco in them and they enhance the risk. And we don't know as much right now, but there is a possibility that they have impact on cardiovascular disease as well.
Absolutely. Dr. Vedamurthy, would you like to continue?
Yep, let's do it. So as far as her exercise, she doesn't do regularly scheduled exercise. She just goes for a walk 2 or 3 times a week, approximately 30 minutes or so. As far as her diet goes, her typical breakfast is like toast with butter and coffee. For her lunch, she has lots of red beans, white rice, some salads, some root vegetables like Yukon plantains, probably one of the most important kind of vegetables she eats. She snacks with obviously some high sugar laden fruits like mango and pineapple. And as far as beverages, she mostly consumes water, except when she goes out, when she has some sugar sweetened beverages. That's a little bit about her exercise behavior, diet and behavior.
Excellent. And so as we look at diet, how does that tie into things we already know about her and things we still would want to know about the way she cooks, about how she has approached her diet over her lifetime? Dr. Nazir, would you like to take that?
Well, one thing I'm noticing is she seems to be on a plant-based diet. I did not see anything listed that wasn't plant-based in here. I mean, the butter, if we go into the specifics of what a plant-based diet would be, maybe that would be considered because it's got the dairy in it. But otherwise, it seems like a very like it's all plants and vegetables and lentils and whatnot. I know we've got a question from one of our other colleagues to say, you know, how is she cooking this? If everything is fried, is everything baked, is everything sauteed, and how is that prepared? I think that would be a little bit more important. And then, of course, this is great that it is all plant-based, but there is a lot of sugar in certain types of fruits. When the amount that she's intaking is very, very high versus not so much. Is her coffee full of sugar? Is her fruit juice very high in sugar? Just getting those types of things for sugar intake, but also caloric intake can help as well.
Yes, and specifically as far as the cooking, it mentions some butter on her toast, but oils, things like that. Did anything like that come up, Dr. Vedamurthy, of any alarm bells on how she's cooking things?
To be honest, so I just took the basic story. Then the plan was to refer her to her dietitian to sit down and have a big conversation. So I didn't have the full details from the dietitian yet, but yeah, certainly a conversation she should be having with her dietitian when she meets them.
Absolutely. Another good question about lifestyle that we have from the audience is about sleeping patterns. And for Dr. Shapiro, when does sleep play a role in someone's health and cardiac health? Is that a good question to ask during a visit?
Yeah, it's a great question to ask. It's become taking on more of a prominent role, I think, in recent years, and something that we do screen for. But actually, before we get into that, you know, I agree with the comments about diet, probably suboptimal. We'll probably get more into that in a little bit. But I have to say, coming from North Carolina, this isn't the worst diet I've ever seen, but definitely there's room for improvement. But I'm also actually quite concerned about her level of physical activity, because she's not getting anywhere near what she needs to sort of optimize cardiovascular health with 2 or 3 walks a week that are about 20 minutes. We can get into exercise counseling perhaps a little bit later as well. But yeah, I think all of these things are important to do as you did, screen for it, but then also give her specific tips on what she needs to do for exercise, how she might need to modify her diet, and what we consider to be optimal levels of sleep, which is actually perhaps the hardest one to deal with.
Yes. And are there any starting points or things you would do before counseling her on exercise?
Yeah, you know, I've really moved away from sort of the typical prescriptive exercise of try to do 30 minutes 5 days a week into step counting. There's a lot of literature now to suggest that step counting is probably the preferred way to counsel individuals on physical activity, and probably for a variety of reasons. I think perhaps most importantly is when we used to give counseling about how many minutes per day or how many exercise sessions you need for a week. That was before we appreciated sort of the deleterious nature of prolonged sedentary time. So I think people kind of psychologically check the box, I've done my 30 minutes of exercise for the day, and then they could actually be quite sedentary for long periods of time. And when we used to think that, sitting was neutral, maybe that was okay, but we now understand that prolonged periods of sedentary behavior is actually detrimental. Step counting helps us to get away from that, because in order to meet your step count goals, it's very, very difficult to have really long periods of time where you're doing no physical activity. And there's specific guidance on how many steps men and women should get according to age. And it's very easy to say, this is the amount of steps that you need to strive for over the weeks and months as we're working together. And most mobile phones have a step counting app. Certainly many people have devices like a watch, but also you can go to a pharmacy and buy a pedometer for about $15. So it's a very effective way of counseling patients on physical activity.
Absolutely. And as you were mentioning about being sedentary and whatnot, that struck me with her profession in the past as a hairdresser. It's probably not one of the worst professions. She's forced to be on her feet, but it's not necessarily a sedentary job by any means. She's standing and moving around all day long, which was interesting. It was nice to see that she was going on a walk regularly. In the interest of time, let's move on to family history.
All right. So for the family history, her father had a heart attack at the age of 50, but he's still alive. Paternal uncle had a heart attack at the age of 45. He's alive too, but the uncle smoked, father didn't smoke. Mother has a history of diabetes. I think that's pretty much the most positive family history she had. No other significant family history.
And so where does this direct your thoughts when you see family history? What things here? We have some bold points, I assume, for a reason. So let's talk about those.
So clearly this is highlighting that there is a presence of a family history of premature coronary artery disease. That's a significant, especially when you see it in a man less than the age of 55, it is highly significant. Especially, at least the uncle had a confounding factor of smoking, but the father did not have that. So that it makes it more significant. And mother has a history of diabetes type 2. So clearly lots of bad genes at play.
Excellent. Do our panelists have any commentary about family history and how you use that in determining your steps in screening?
Well, yeah, I think we were already sort of on edge from the very first slide, given some cardiovascular risk factors that emerged right away. But now you throw on this family history. You have 2 family members with, early heart disease. We're really starting to think that she's at, high risk for ASCVD. So, you've got our full attention, Dr. Vedamurthy.
Okay, thank you.
But and then Dr. Levis, to answer your question, I do think this will inform some of the biomarker testing we'd be interested in doing, I think, as you're indicating.
Yeah.
And Dr. Nazir, when you see that the father had an MI at age 50, do you say, oh, well, this is a woman, they don't get heart disease as aggressively or as early, so I'm not quite as worried. Lucky she's the daughter.
No, because it's a risk factor. It is family history. Regardless, it meets that criteria for early onset of heart disease. So it doesn't differentiate between if you're the son or the daughter. It's your family history. So I definitely would be very concerned about, and I'm glad that it's bolded, so it makes us know that we should be concerned about it. But of course, it is the early onset of ASCVD. It's that enhanced risk factor. We got to be very cognizant about it.
Well, I'm glad you brought this up, Dr. Leviskin, because I think that still, even in 2023, this is unfortunately still too common in the way some healthcare providers are thinking. So she may have heard that before. She may have heard, well, there were a couple of men in your family who had early heart disease, but you don't need to worry. So we do we have to specifically call this out to her and tell her, I'm quite concerned about your family history. This may be putting you at risk for early heart disease as well. We'll have to actually explicitly talk to her about that.
And what in her OB-GYN history makes us particularly alert and worried at her current age and changing health status?
Yeah, I think that it was mentioned that she's perimenopausal now. So, now we're going to see an escalation in risk, as estrogen levels are raised.
Absolutely. And I think this is a key point that is so crucial to make, is that we now know that as some of the disparities in health are coming to light and why cardiovascular events may be increasing, is that it's certain groups that we've left behind, and women is the largest of those groups. They tend to be more undertreated, treated later, get on treatment and left on a lower dose and things. So I think it's absolutely key to have, thought leaders like you that pick that up, and that we continue to spread that message that we can be doing so much more with just even the basics. So perfect. Well, let's move on to the next piece of the puzzle, Dr. Vedamurthy.
Sounds good. So I didn't mention the Revio systems, but rest of the Revio systems was completely normal. Okay. All right. So going on to physical exam, her blood pressure, she doesn't measure her blood pressure at home usually. Her first blood pressure reading was like 160/90. Her heart rate was 90. BMI was 32, and her waist circumference was 34 inches. She is otherwise pleasant. She's got some psoriatic patches on her extensor surface of her elbows. On examination of the head, she doesn't have any markers of FH like corneal arcus or xanthelasmas. Her lungs are clear. Her heart sounds are normal. There is no systolic murmurs. Abdomen is pretty much soft to touch, no palpable organomegaly, but she clearly has visceral adiposity there with the increased abdominal girth. And extremities, as I mentioned, there's no pedal edema, no tendon xanthomatous that would raise my concern for FH. That's about the physical exam.
So Dr. Nazir, how do you feel about this physical exam? Do you feel like it gives you a pretty thorough picture?
I think it matches what it's like an expectation from the history. I was expecting this. If it wouldn't have kind of been like that, I would have wondered, had we missed something, if something else is going on. Of course, can do a little bit more from a heart exam. I think we can always go into the details of it, but there may be some imaging or other testing coming up to help with that. But really, it does match what I was expecting to have this type of blood pressure. Her BMI is elevated. She has, central obesity. I think these findings are correlating with what I was expecting. She's got psoriatic patches indicating, some level of disease activity as well from her TID. So I think this exam, and yes, we can always ask for more, but at least right now it correlates with what was presented. It kind of matches up and shows that there are things to work on, even from an objective standpoint.
An interesting note here is that her BMI is 32, but her waist circumference is only 34. Do you ever notice flaws in the waist circumference and how to assess that?
I think, unfortunately, flaws in both BMI and waist circumference are inherent because sometimes individuals are providing that information. My height is this, my weight was this, and it is written down and noted in the clinic. And then who is doing that? What is their education and how to measure these things, how to take these things? Are they doing it at the same location all the time? With many layers of clothes, without many layers of clothes. So it's just so many factors that go into it that then make these differences happen, which then ultimately impact these numbers that we start treating patients on. So it's always good to reconfirm or understand who's obtaining these measurements and, have a good discussion with them on how best to do it, because it then helps us treat these patients better.
Absolutely. Great points. Well, let's move on to the next slide, and then we can always come back if there's anything else we think of.
I just put, just to be complete, we did get an office EKG when she came in, and that was completely normal with normal intervals, no evidence of LVH, nothing of that sort. Okay. All right. So she did have some blood work prior to coming into the office, and this is her basic CBC and CAM panel. Her CBC is completely normal. Her renal functions are completely normal. Thyroid hormones are normal. Her urine is negative for any kind of protein. Her total bilirubin, alkaline phosphatase are normal, but her AST and ALT are slightly elevated, less than 2 times the upper limit of normal, but they are elevated. Her uric acid, our lab normal calls 7 as the high limit, so she's slightly elevated at 8 milligrams per deciliter. Her glucose is at 105. and A1C is 6.2. I have more numbers in it, but I can pause here in case if you have any questions.
Yes, there's a lot there. Dr. Shapiro, I'll let you have first stab at these labs. What surprises you? What doesn't surprise you? What is very important for you?
Sure. Well, I'm reassured that her creatinine and her microalbumin are normal. Concerned about seeing her blood pressure. Of course, that's only one data point, but if she had chronic uncontrolled hypertension, I would be concerned about its impact on kidney long term. At least at the moment, that appears to be okay. With regards to the transaminases, I think we're probably all thinking the same thing. This may be indicative of hepatic steatosis. Certainly she has some of the characteristics. Her BMI is elevated, and we see here that there's some dysglycemia and in A1C that's in the prediabetes range. So this is all kind of fitting into the sort of the MAFOLD, potentially MAFOLD phenotype. So that is quite concerning because that independently contributes to cardiovascular risk as well. So those would be my major takeaways from the labs that we see thus far.
Do you think this is a reasonable amount of lab work? Would you have done all of these labs? Do you think that those are all useful for you?
Yeah, I do these. I do these as a matter of routine, but yeah, I'd like to see a lipid panel as well.
Coming up next.
Yeah, Dr. Nazir, do you have any other comments or questions on that?
Yeah, of course, also the glucose, the glucose A1C are higher than the normal, so these are concerns with the waist circumference, that she's going down a metabolic syndrome pathway. So another diagnosis to add on with what she came in with. So along, and then of course we are looking for these lipid labs to hopefully show up soon.
Absolutely. And Dr. Vedamurthy, we have a question of, did she have any lipodystrophy of any sort on her exam?
No, not except for the phenotype we just described. No evidence of ectopic fat deposition anywhere else. Her thigh was like normal circumference, wasn't too thin, and she didn't have any gluteal fat pad atrophy or anything of that sort. No.
Excellent. You can go ahead and move on to the next.
All right. So coming to the lipid panel.
Here we go.
This is the lipid panel she came to the office with. So this is what we have. Her total cholesterol is 239. Triglycerides is 400 milligrams per deciliter. HDL is 34. And the calculated LDL cholesterol by Fried-Waldy equation is 125 milligrams per deciliter.
Excellent. So at first, when I saw this slide, I thought, oh, there's so much missing. But I think that with the variability in labs across the country, there are times when this is what's printed out for a lipid panel, depending on where you practice. So based on this, to our lipidologists, Dr. Nazir, do you want to take first stab at what this tells you?
Yeah, absolutely. And also going to your point, sometimes because if this patient, which I think, we're going to discuss a little bit more, hopefully towards the end, this patient could be in anybody's clinic and you may not have access to all the labs and all the specific lipid parameters that we discuss and we talk about. So you get this and hopefully, it does provide a significant amount of information, one being that everything is not in the normal range. So triglyceride, I think this helps us understand maybe if we didn't get that detailed information from the diet intake, that her diet does have quite a bit of fat, cholesterol, something going on to bring that triglyceride to that level. And then her LDL cholesterol, somebody just showed you that and you didn't have any risk factors and whatnot, and you're like, oh, this is okay. But in the setting of our patient, I think this LDL could also have a little bit of work on. And the HDL is low for, she's perimenopausal, but not menopausal. So I think it may be a little bit on the low side as well.
Dr. Vedamurthy, was this a fasting result?
Yeah, this is a fasting. One piece of detail I could have probably put there is that 125 LDL cholesterol on the normal distribution falls around the 60th percentile, if I'm correct. Just thought I'll throw that out as well. Yeah, this is a fasting sample, yes.
Dr. Shapiro, what do you feel about the authenticity of the LDL cholesterol when you have triglycerides of 400?
Yeah, you're exactly right. So we're going to start to be, the Friedwald equation is going to be falling apart at this level of triglycerides. So we may actually be getting an underestimate of, true LDL cholesterol here. But I mean, I think the lipid phenotype here is, very characteristic of one who's insulin resistant to the high triglycerides, low HDL cholesterol, kind of mildly, elevated LDL cholesterol all fits. And then, of course, just looking at total cholesterol minus HDL cholesterol to calculate a non-HDL cholesterol, you're going to get about 205, it looks like, for your non-HDL cholesterol, which is, really quite high. So that, suggestive that there's a lot of atherogenic lipoproteins, ApoB containing lipoproteins, and that might not be as obvious by just looking at the LDL cholesterol here. The other thing that I think I would just add to, I'm sorry.
Oh, I was just going to say, I was surprised that they managed to calculate an LDL cholesterol, because most of the time when the triglycerides 400, I always see not calculable, couldn't calculate. So we got a number, and like you're saying, Dr. Shapiro, it's likely inaccurate.
And I think that's one of the poorest understood things by the average person is they don't realize that that is a calculated level with an LDL cholesterol. And many clinicians don't realize that as well. And so they would take that. Dr. Shapiro, did you have more that you wanted to say about that?
Oh, I was just going to add that, obviously the standard lipid panel is a great way to start. But as we were talking about with the family history, there may be other lipid fractions that we want to measure. And I'm not sure if that's going to come up or not. So I'll wait.
And so when are some of the things that you would like in addition? Or we talked about the problems with the Friedwald equation and things. What are some things that in someone's lab they could order perhaps? And what are the things that are kind of luxury items, but that we'd love to know?
Yeah, right. So where I was going at, one thing that I think would be mandatory is to get a lipoprotein A, given the family history of premature ASCVD. In terms of a luxury item, I don't necessarily think it's necessary in this case, but you could contemplate also getting an ApoB level here as well.
Absolutely. Well, I know there's many more things. So Dr. Vedamurthy, let's move on.
Sounds good. All right. So at the time of this visit, we kind of calculated her 10-year ASCVD risk using the standard pool cohort equation, and her 10-year risk came as 5.8. And so this is where she falls under the nomogram. And it says if risk enhancers are present, then begin risk discussion regarding moderate intensity statin therapy. So that's where we started with. And of course, we ordered some more advanced testing for her subsequent office visit, and I can proceed to that test if you're ready. Actually, yeah. So I think just kind of summarizes what kind of ASCVD risk enhancers she has thus far based on this first office visit itself. So she has a positive family history. She has metabolic syndrome here. She has evidence of inflammatory disease. She is Hispanic, so that potentially constitutes a risk enhancer as well. The triglycerides are elevated, more than 175. Yeah. So just with the first visit, we are able to kind of say that she's somebody in the moderate risk category with lots of risk enhancers. Okay, and then, okay, I can probably pause here. I mean, we made some changes. We made some recommendations for her, but I would like to obviously hear what the panel would think as to what they would do before she comes back with their second set of advanced labs and further testing. Thought would be a good idea to discuss about what would be recommended during this visit, the initial visit.
Absolutely. So when we look at all of these questions, I would say let's summarize it as for each of you, what do you think about as your first inclinations of what you'd like to see her on just in general? Would you like to see her immediately on medications? What is your access to lifestyle modification and how would you set that plan? What medicines, if this is someone who is perhaps a little squeamish about taking medicines, what would you set as your priorities right now before we get any additional testing? If you only had that for today.
Well, I would say that, the lifestyle discussion is going to take the center stage, at least immediately at this appointment. I would start talking about physical activity, as I was alluding to, in terms of step counting goals. Like Dr. Vedamurthy mentioned, I would also refer this individual to see my dietitian. Fortunately, we also have a wonderful dietitian as part of our group. And it really does require a good 45 to 60 minutes just focused on nutritional interventions to improve cardiovascular health. So that's where I would start, at least lifestyle. And then in terms of medications, if she was squeamish, it depends on how squeamish. Squeamish, sometimes they negotiate, well, I'm willing to take 1 or 2 medications, or you need to prove it to me that I need to take a medication. That's a little bit different discussion. I think based on if she's willing to start a medication, I think just based on the quantitative risk assessment using the pooled cohort equation, and then all of the risk enhancing factors, which I think was a major advance of the 2018 guidelines, because you see she was sort of in that borderline zone of risk. She was between 5 to 7.5%, and I think we all feel that she's at much higher risk than quantitative risk assessment would suggest. And then you showed us about 4 or 5 risk enhancing factors, Dr. Vedamurthy. So I think we can confidently say, well, we're going to reclassify your risk upwards. We're really quite concerned. So I would definitely already advocate for statin and potentially even a blood pressure medication, though I'm a little bit, that's just a single number. I would like to see additional numbers, but I wouldn't want to wait too long, because if her systolic blood pressure is truly in the 160 range, we wouldn't want to wait too long to get her on blood pressure medication. But if she was really quite reluctant to start a medication, sometimes doing subclinical athero imaging can be quite helpful in motivating patients to start medication. So coronary calcium would be consideration. I don't personally think she needs that to start medication, but sometimes to get patients motivated, when you uncover subclinical atherosclerosis, they feel more compelled to start a medication.
Absolutely. And we had a good question from the audience about strength training as part of her prescription. And is there any use in that? And is that part of your prescription at times?
It absolutely is. I would say, though, in an attempt not to overwhelm this individual at the very first appointment, we have to pick and choose what it is that we want to emphasize. But hopefully we're going to build up a longitudinal relationship where we can layer on additional recommendations as they're having success with some of the early recommendations. So I think absolutely strength training is incredibly important. I think, though, I would probably start with just moving as the initial recommendation for exercise.
So to either of you, if you had 2 additional tests that blood tests that you would order, pick 2 additional advanced tests that you would like to have. Is there anything you need beyond what you have? Are the fancy things, are they things you would like to know on her?
I'm still waiting for the lipoprotein little A.
Excellent. And what about an ApoB? Would you like to know an ApoB? Is a non-HDL enough for her right now?
For me, her non-HDL, I think, was over 200. For me, that is probably sufficient. So I don't feel as compelled to have ApoB, but I wouldn't be opposed to it.
Yeah, I think if we get the option to get additional testing, I would definitely go for the labs Dr. Shapiro mentioned. But there is quite enough information, and we've got data that we need to be aggressive with lifestyle modification, and there may be medicines already to start right now. I think if the patient needs further motivation, further information, maybe in this case, I would say let's do the additional testing and let's get the additional imaging. But right now, being this patient, I'm ready to definitely let's get lifestyle modification plugged in, and let's kind of start talking about, think about pharmacologic therapy as well.
Excellent. Well, let's move on to the next slide and see what we have to offer.
Right. So she comes for a second follow-up visit with additional labs. Right, so now we have the non-HDL cholesterol, that's close to 200. ApoB is 130 milligrams. This is at the 90th percentile when compared to our calculated LDL cholesterol, which was, even though not probably accurate, but still was at the 60th percentile. Lp(a) is 120 milligrams per deciliter, 4 times the upper limit of normal. and high sensitive CRP came back as 2.5 milligram per deciliter. And probably pause here.
Yes. So what additional information did this give you?
So Dr. Vedamurthy picked the perfect number for the ApoB of 130 because that's the number in the guidelines that says the ApoB of 130 indicates an LDL of 160. So that LDL is out. I mean, we already said because of the triglycerides being at a number of 400, it's very difficult to get a calculated LDL that's accurate. So we know it's much more higher than that. And of course, the lipoprotein A is significantly elevated, which increases her risk for ASCVD, both stroke, both MI. So very helpful information to say, I would say we need to do things to medication pharmacologic advice before we leave clinic today with this data now.
With lipoprotein little a, is this a reading that alarms you? Is there anything different about it being 120 versus lower?
Right. So I think we were all thinking that there was a certain likelihood that her Lp(a) would be elevated, but to your point, this is substantially elevated. So in the mass assay, which was used here, the one that's measured in milligrams per deciliter, the typical threshold at which we start to think about Lp(a) related risk is at about 50 milligrams per deciliter and above. So a reading of 120 milligrams per deciliter is substantially elevated. That's probably well into the 90+ percentile. So it's quite concerning, though not surprising, based on the family history. And I don't think the other labs are surprising, except for the hsCRP, which I thought might be more elevated than it is.
For sure. And is it very common that you would order an hsCRP?
I personally don't order it very commonly.
It's nice in this case to have it, but not something that you would consider an essential, either of you.
Yeah, just a selective use for being.
Yeah, selective. I think especially the patients with the CID, if their disease is stable, not active, you have to take into account that when you're ordering these type of inflammatory markers, if it's elevated because their disease is very uncontrolled versus their underlying cardiac disease inflammation contributing to it. So
absolutely. Well, let's move on to the next slide so we make sure we get to all the points, and we can always come back to talk about a couple other things here.
So this is her coronary artery calcium score. It's at 85, and on the nomogram, she's at the 96th percentile for her age and race.
And so is a calcium score something you would have ordered at this point, Dr. Nazir?
no, I think Dr. Shapiro mentioned also, and I wholeheartedly would have agreed with him. I think there's so much substantial information. From my standpoint, I wouldn't have ordered it, but if the patient needed something else to say that, well, why do I need to be on these medications? Help demonstrate that. But from a clinical information and the way the case has been going, I think we have quite significant information to say from our standpoint, you need to be on pharmacologic therapy. We need to get things going in addition to lifestyle modification. But of course, if the patient is still very hesitant to show something to support that, that would be the only reason I would recommend.
Dr. Shapiro, what about you? What does the calcium score do differently, if anything, for you? And at what point would you bring it into a patient's care?
Yeah, I agree with Dr. Nazir, though I am definitely a calcium enthusiast. I use it frequently in refining risk assessment and primary prevention. I don't know that it was necessarily needed here, unless of course she needed to be persuaded. But to be honest, now I'm very glad that we have it, because I thought she was high risk before, but now I'm really concerned. I mean, she has what I would call accelerated coronary atherosclerosis. A woman of her age should not have a coronary artery calcium score of 85. So she started to accumulate coronary atherosclerosis at a very young age. This, of course, ties into all of her risk factors, the Lp(a), the family history. I think now we really have to make a very compelling case for her. Like, look, we need to intervene. If we don't, with lifestyle and medical therapy, if we don't, the natural history is this going to be further accumulation of atherosclerosis and concern, obviously, for ASCVD events. And unless, of course, we really do something to change the trajectory here, we'd be concerned that she would have premature event like some of her other family members. So I think actually looking at this calcium score now, it's extremely useful.
So we have some very astute attendees tonight who have some wonderful questions for us. And the questions, with the amount of information we now have, where we know that Lp(a) is elevated, we know her coronary calcium score is elevated. Now, where does this set your goals for her LDL and non-HDL? Where does it set your thought of an aspirin? Where does it set your aggressive level for blood pressure? How does this change your tune?
I was very hesitant to let her leave my clinic without pharmacologic therapy. Now she's definitely not going to leave without pharmacologic therapy for her high cholesterol, for her blood pressure as well. Lipid-lowering therapy, I think starting with statin therapy, hopefully will be impactful to get her LDL down by at least 50% or greater than what she has right now would be our first goal. And that's usually done with a higher dose therapy. And then the blood pressure, it's 160/90, and she has this is our one reading, of course, but she has a history of it. So she may be in the stage 2 hypertension range. She's got to be started on at least one agent, if not two, depending on what agents are started and what else is going on. But I think it's going to be a little bit more aggressive pharmacologic therapy in somebody who was initially a little hesitant to take medication. Honestly, in addition to the lifestyle modification, we're going to definitely recommend.
Absolutely. We have some very good questions about where the calcium score falling would change your opinion, if she had had a 0, if she had had higher. And just to kind of summarize as we get close on time, we now have this expert consensus decision pathway from last fall from the ACC that gives us a little bit of clarity on how to use a calcium score, and a little bit more that we may see coming in the future. So we now have a woman that doesn't have a CAT over 100, but she does have one greater than 75th percentile. So it starts to move us in that pathway of maybe not a moderate, but a higher intensity statin perhaps. And where does that start to tilt you based on that, as far as a 70 versus 100 and additive therapies besides a statin for the future, knowing that she may be very overwhelmed if too many things are presented at one time? In your long-term goals, what are you thinking you would like to see her at?
I will just say very briefly, I think lower is better. I also think she was Hispanic, which we mentioned, and her ASCVD risk calculated score may not be appropriately estimated because it's not that ethnicity is not part of the calculator. And with all these other factors, with the coronary artery calcium score up 85 at her age, she's getting, and CID, chronic inflammatory disease, all pointing to maybe an aggressive, and everything, and the ApoB and the LPA at such a high level. Lower is better, as capable as we can get lower, with pharmacologic therapy, lifestyle modification. I'm going to be really recommending that for the patient.
Absolutely. I'm going to let Dr. Vedamurthy move to his final slide, just so that we make sure to.
So this is what I think we had the luxury of testing out this new tool we had. We had a polygenic risk score for coronary disease through a company called Lilica. So we were able to provide this test free of cost for her. And her score came up high in the 84th percentile, indicating a 2-fold increased risk of coronary disease. So yes, we were able to provide it. Usually, I think patients get charged close to $150, but we were able to provide her free of cost. So that's why we put this, we got this test for her.
Excellent. And does anyone feel like this was necessary in this case if it hadn't been free?
Absolutely not. I mean, I think maybe you could make the case 30 years ago, but horses out of the barn. She's got way too much coronary atherosclerosis, and she's at substantial risk that we need to modify at this point.
Absolutely. Wonderful. Could you just, in our last minute, give us a synopsis of what you did this first visit, or what you were able to accomplish in the first couple visits with her? Any follow-up that you had?
Yeah. So we convinced her to try a low dose statin first, low dose of a high potency statin, just because she had that fear of statins giving her muscle pain. So we said, we'll start with a low dose, probably even do alternate days just to see how well she does with that. And then we did also start her on a blood pressure medication, and we did advise her to meet with a dietitian. Yeah, so those are the two big things we made. We started her on a low dose statin, low dose of a high potency statin, and we started her on a blood pressure medication. I think we started her on one of the ARBs. Yeah.
Excellent.
And she's due for follow-up in a few months.
Excellent. Dr. Shapiro, how do you feel about that plan?
Yeah, I mean, I think we have to work with patients where they are. So I think that that's a huge victory that you got her to be open to starting a statin. Any dose of any statin is way better than no statin. So that's a victory. And the fact that you got her on a blood pressure medication as well to see a dietitian, I think that's an outstanding start. And, close follow-up.
Excellent. Dr. Nazir, any parting thoughts on this and anything else you would set as your ideal goals for the next visit?
I absolutely agree that getting patient on some medication is better than no medication, but I think, she'll benefit from close follow-up and almost her medical issues are all so much related to cardiovascular disease. I think it would be very appropriate, maybe seeing her in 1 month afterwards, be it in your clinic or in a support clinic to see if her blood pressure is doing okay, her tolerating that statin medication, and the lowering therapy is going in the right direction, and then having a follow-up in 3 months right before that with some lab work to see that the medications are doing the work they need to do on the lipid levels. But really close follow-up is going to hopefully help the patient also maintain that lifestyle modification, but also ensure that she's on medications, pharmacologic therapy that'll benefit her as well.
Excellent. Well, I would like to thank our panelists and our presenter tonight. Really appreciate it. We're 2 minutes over. Thank you for sticking with us and for the wonderful questions. We had a lot of really great questions from the audience as well. So thank you for listening so much. And we hope to see you all again soon. And I think this patient is on a good track to better health. And I think she would have been in any of your clinics. So thank you very much for the good care you give.
Thank you.
Good to see you all.
Thank you so much.
Thank you.
Dr. Vedamurthy.